caused by many different things, which we'll get into on, there's different causes for this. And a lot of people who are on the spectrum, ASD or ADHD, they might have a higher chance of having an intellectual disability or, IDD or ID, what people call it. So there are a greater likelihood of comorbidities within the neurodevelopmental diagnoses. So it's super confusing. And so I myself am falling into that category. I'm in the neurodevelopmental diagnoses. So it's interesting to see such a spectrum of people can qualify under that, but they're so distinct. But today I just really wanted to make sure that everybody knew what we're talking about is the difference. It's specific. It's 3 kind of different DSM diagnoses that are, I'll show you right here. Here's our overview. We're going to talk about severe mental illness, ID or IDD, the intersection, challenges. Yeah. Okay. Anyway, I want to get into it. First, I'm a dork, as you can tell. I have been in trainings where I feel like I learned maybe something, but then I was like, what am I supposed to do with this? How am I actually supposed to functionalize this in my practice? I'm a social worker. I'm a clinical social worker. I want to actually do something with what I learn. I've always been like that. I feel like everybody that comes to these wants that. So I learned this action framework a long time ago at a training, and that's what I like to use. We like to start with what, so what, now what. And that's how I'm going to frame this, where we're going to start with what are we talking about? So what, meaning why does it matter? And then now what are we going to do with it? So that's kind of what I'll be touching base on throughout with our action framework, how we're going to use this information to apply to people we might help in our lives or our own lives. And those of you who've seen my other one, this is exactly the same information from last time, because severe mental illness is severe mental illness. The information has not changed, but it's still important to define what it means. And severe mental illness, it's a mental, behavioral, or emotional disorder that significantly interferes with somebody's ability to function across life domains. And so that means their personal relationships, their job or their school. In the United States, when we think of life domains, we think about their ability to take care of themselves, their ability to function in a social environment, all of those things. And it's multiple life domains. It's not just, oh, I'm having a hard time at school sometimes. It's significant impairment. They can't keep a job if they need to. They can't financially support themselves. They can't function in a community. They can't do transportation, multiple functional impairments. More than 11 million older adults in the United States are experiencing severe mental illness at any given time, but researchers are suggesting that that's actually maybe less than what's really happening, because people are going underdiagnosed, misdiagnosed, and undertreated, even if they are getting a diagnosis. So things like bipolar, where there's a higher chance of psychosis or psychotic episodes, where people might have really intense manic episodes, even psychosis over a really gnarly major depressive episode could be considered severe mental illness at different times. Schizophrenia or schizophrenia spectrum disorders are really what people consider classic severe mental illness. I know that's a weird thing to say, but it just came out. Things like hallucinations, delusions, disordered thinking that really impair people's ability to access their environment in a way that makes them feel good in the community. Things like that. Even really intense PTSD, people can have psychotic elements over it, where they cannot access reality. So if we think about severe mental illness, there's usually that element of, at some points, where reality isn't what it used to be for that person, and they are unable to function the way that they need to in their society, their home, and in their own life. And as you can imagine, there's higher rates of disparities for people who experience SMI. And think about the way we treat people, even if they say that they have depression. They say, oh, I'm depressed. They don't even say I have major depressive disorder. They say the word depression, and people get a reaction. Now, this is where we're getting into what is intellectual disability or intellectual developmental disorder? And I love how you already all were talking about it, because I wanted to know what comes to mind for you all when you hear these words. Obviously, things like autism already came to mind for somebody, and that's okay. What else comes to mind? Feel free to unmute or write something in the chat, anybody. What else might come to mind? Please don't all speak at once. It's going to overwhelm me. Okay, there we go. Thank you for your help. I appreciate it. Borderline IQ, okay. And do you say Jasmine, or do you say it differently with the spelling? I don't want to say your
Yep,
name. Okay,
just Jasmine.
People mess it up a lot, I bet.
Yeah.
So when people typically, when they say borderline IQ, they mean something that's probably typically under a 70 IQ, which used to be called, they used to call it mentally retarded. That was the cutoff. So a lot of times people associate under a 70 IQ with intellectual disability. Very good. That's been longstanding. Anybody else? What comes to mind when you hear these phrases? It's okay if you don't have
Kind of the same
anything.
as Down syndrome too.
Yeah, Down syndrome can be included. Yeah, Down syndrome is often associated with this. Excellent.
Deficits in adaptive functioning.
Boom. That's like the key phrase, deficits in adaptive functioning. Adaptive functioning is almost always the key biggest phrase. If you remember one thing about intellectual disability or ID is adaptive functioning. That is the piece that matters. That is the piece that needs to be targeted for support. Excellent. Somebody's writing something. Learning disability. Yeah, often learning disabilities can be included. Perfect. You guys are getting it. Okay, great. So this is just a bunch of crap that's on there. This is exactly word for word from the DSM, but to get a diagnosis in it, you have to meet the 3 criteria, which are deficits in adaptive functioning exactly across multiple domains. Like we mentioned before, that sounds like criteria of other mental health diagnoses, right? It's the same kind of criteria where you're having deficits in functioning, but there's more of a focus on adaptive functioning. And you have to have also deficits in intellectual functioning, like reasoning, problem solving, which I also work in the dementia space. So there's a lot of cognitive functioning that mimics things that happen when people have a neurological issue that might happen later in life. So there's a lot of parallels in that if anybody has ever worked in a dementia space or a neurocognitive space. And then a big key thing about onset or origin is that it has to happen during a developmental or earlier childhood, adolescence, and not adulthood. So if something's acquired during adulthood that looks like an intellectual or developmental disability, it's typically more along the lines of a traumatic brain injury or a medically acquired thing that mimics it. Otherwise, it's not developmental. Developmental exclusively refers to childhood or adolescence. So the 3 diagnoses that fall under this are the intellectual developmental disorder, also known as intellectual disability. And then, as those of you who know about the DSM, they love to add a diagnosis under a grouping that's called unspecified for when you can't, you're like, you know, it's in that grouping, but you can't quite meet all the criteria, but you're like, hey, it's there. And it's really good that we have that, because you know that you've met the people and there's some reason why you can't get all of the information, but you know it's there. And especially with somebody with an intellectual or developmental disability like this, there's going to be deficits in the ability to communicate in the way that we're accustomed to or able to assess or evaluate. So they use it in kids 5 or older when assessment that we're accustomed to is impossible or limited because maybe there's too high a sensory or physical impairments, or those comorbid mental, like maybe there's schizophrenia over it, and it's too much overlap to understand what's coming from what. Or there's a other neurodevelopmental disorder, like somebody was talking about, maybe they're also meeting the criteria for autism spectrum, and you're like, whoa, I can't quite separate these 2 out, but I know that there's elements of everything. cultural and linguistic barriers, this is one of the times in my clinical experience that I have seen linguistic barriers really, really, really impact assessments when there's already communication issues. I've never had so much trouble. Like, I can always get a translator. I've always been able to get a translator for everything I've ever needed, but in this case, sometimes a translator doesn't even do it, because translators also, they're not taught how to translate behavior or a quote unquote atypical communication. They know the language. So if somebody's in a family that speaks Spanish, they come to translate the Spanish, but they don't typically know how to communicate with somebody who already has impaired language. Just because they know Spanish doesn't mean they can understand a person who might have impaired Spanish. So that has been quite a difficult barrier in my own experience. And then when the developmental or behavioral challenges are so significant that assessment is almost impossible. And that's why I always love a good unspecified. Also at the beginning, when you know you need to have a diagnosis to be able to start like billing and get service, you can tell that they're in this cluster, but you don't have all the information yet. You can put that as like a placeholder until you get all the information, because you can update your diagnosis. Remember that. When you get more information, you change things to reflect that. Don't just stick with your first choice, because new information changes things, everybody. Oh, did I made it twice. Oh, no, I titled it wrong. Oops. This is supposed to say global developmental delay. Oops, I'm sorry. So global developmental delay is the same vein, but it's used for kids under 5 only. Because typically, when there's such significant impairment from an intellectual or other developmental disability within this vein, when there's a child under 5, language is really, really impaired, and they're unable to access the assessments that are typically done to show that somebody has this diagnosis. So as long as you can show that they haven't met developmental milestones, which are really outlined. Like if anybody's done any developmental work, there's really specific milestones and age times when kids are supposed to meet them, like walking, talking, saying amounts of words, things like that, pointing, rolling over, things like that. If they don't meet certain milestones across 2 or more developmental domains before 5 years old, and when there's clinical suspicion that there's an intellectual disability, but they're too young for that standardized testing. And then there's also higher behavioral challenges. They can have that diagnosis. And it's often a provisional diagnosis, kind of like if you know anything about how conduct disorder is often given to kids under 18. And then when they're over 18, they're given an antisocial personality disorder diagnosis. It's like here's your placeholder diagnosis until you're older. And then they get a formal diagnosis of intellectual developmental disorder when they're old enough to access the assessments. Excuse me. So in the United States, about 1% of the population qualifies as having intellectual disabilities like this. That's 10 out of every 1,000 people. And they qualify it like many diagnoses in the DSM. There's a mild, moderate, severe, but there's also a profound way of qualifying people with these diagnoses. And it's about support needs. It's about that functional adaptive ability. So it's not about intellectual IQ. It's not about IQ, because actually the evidence shows that after, I think it's about 70, the 70 cutoff, it really doesn't matter how low it is after that. There's really not a lot of difference in functionality. So that's why they really move to adaptive thing, that the numbers don't really matter, the correlation between assessments and IQ after that point don't really make a difference. So it's the focus on adaptive functionality in domains is more important. 85% of the people who are diagnosed with this are considered mild. But they're all about support needs, like how autism was reformed into having high support needs, low support needs, moderate support needs. More males than females are diagnosed with intellectual disability. And it still surprises me every time I know this, that there's no real disparities and there's no real differences based on race or ethnicity. So it's an equal opportunity based on race or ethnicity at least. And it's really important to note that many, even despite having the mild, quote unquote, mild qualifier, many need lifelong caregiver support. And the caregivers are often typically a family member, like a parent, and they are often the mother. And the support happens early in childhood and continues until that caregiver dies. And many of the caregivers, they're doing caregiving into their older adulthood. So it's often a lot of women who end up becoming single. So a lot of when we'll get into the treatment and assessment considerations, because there's a likelihood for more support needs. When you're thinking about assessment and treatment of a person who has this diagnosis, you need to think about engaging the support system, because treatment is not just about the individual, as we know. Treatment is about how are we engaging the informal and formal supports and knowing what the person has to set them up for success. And mental health disorders in general, not just severe mental illness, 3 to 4 times more common in individuals with ID or IDD than the general population. That's a big difference. 3 to 4 times more common. 30 to 50% of people in this category, they have that co-occurring mental health condition. And they're at a higher risk for suicide because of these associated comorbid mental disorders. There's a higher intellectual and adaptive functioning deficits. I don't like the word deficits, and they have immediate past stressors. So like severe mental illness and any kind of mental disorder in general for individuals in this population, it can often manifest atypically. So it can look differently than we'd expect it to and what we learn in our typical diagnostic courses and our knowledge. So for instance, for the longest time when people were first starting to describe what depression was, and they said, depression is this. Depression is when you have classic hopelessness, helplessness, you can't get out of bed, you're lethargic, you're all these things. And then they realized after that it's different within different groups, like teenage boys often, depression can present as anger and irritability and all these things. So once we realize that different groups based on different things, they have often a different presentation. Somebody's putting a question. Let's see. Yes, so Wendy, I am guessing that you might work with individuals in this population. Would you like to share a little bit more about that? The most prevalent diagnosis you see is PTSD.
Yeah, so I've worked for about 25 years with this population in a variety of different settings, including crisis. Usually the mental health diagnoses, I also specialize with people with very challenging behavior. And usually they have a schizoaffective diagnosis and no history of hallucinations.
Yep.
And it turns out very much PTSD.
And they're like, here's some medication.
Yeah.
Get out of my face and stop having your behaviors.
And the medication doesn't work. And so then we get another medication. And
you're like, why doesn't it work? Because it's not what you have.
yeah.
Wow. And so who's ending up being able to give the people these diagnoses?
Usually psychiatrists, because they do show up with a lot of agitation and anger and anxiety. And so they get the antipsychotic. And I think that's generally where the diagnosis comes from. Also, like ER. The trauma assessments are pretty minimal, even like crisis assessments. They don't, trauma, it says none reported or NA or, you know.
And that's wonderful that you guys are all so smart. Everybody's already talking about the stuff that we're going to get to. I love this. Because at the end, there's in the treatment consideration, we know this. Sometimes it feels like it's like that commercial, should have had a V8, right? Did anybody remember those commercials where they knock themselves on the head? It's like, oh, duh. Like when you talk about it, we know all this stuff, especially when we're in school and we have learned. Yeah, Wendy's cracking up. Or no, somebody under Wendy, sorry. We learn these things like we should be getting collateral sources of information. We should be asking the people in the individual support circle and all these things. And we're often not checking our biases, and we think, oh, we don't have biases. We don't have these things, but people often still have so many biases about people with intellectual disabilities or developmental disabilities, thinking that they don't know what's going on, that they can be treated like an animal, although who would be treating an animal like that either, but that's a whole thing, that they should be subdued. It happens to people with dementia or other neurological issues too, that they don't know how to speak for themselves or advocate for themselves or have a personal opinion. And so they just think, I don't need to ask this. Who's traumatizing them? How would they even know? They don't even realize that they're just not treating them like a person. And person-centered care and trauma-informed care becomes even more powerful to remember. And it's not just words anymore. It's like, oh, wait, how do you actually actualize these things when the ability to communicate in the way we're used to, like the way we're communicating right now, is gone? People don't think about that until, like, Wendy, I mean, you've worked in it for 25 years, so now it's probably just, that's just what you do. But like when new people come into that work, they're just like, I mean, have you seen that when new people start working in that vein, they don't often know and they need to learn?
Or often, like if I'm in just a more generalized mental health setting, I've actually heard more people than I can count say I don't speak ID, which is
Oh
very,
my God.
I can't count. It's too many. But yeah, usually when I approach somebody for the first time, especially if like we're in a crisis, I try to throw them off, like, hey, rough day. Whatever they're thinking I'm about to say, it wasn't that. And they're like, well, yeah. And that, starts off okay.
And so the idea that you're even just, people are being like, yeah, we have all these general facts about how things manifest and how PTSD manifests in people. And we still need to be open that there are quote unquote atypical representations of things. So you seeing people, here's all this agitation and here's all these things. What else could this be? I'm not just thinking that because they have intellectual delays, they can't, it's because they don't regulate, and it's because their brain's just making them aggressive and they can't talk. Okay, how does trauma manifest in the body? What do we know about that? I love that. That's awesome. Just remembering, what all do you know? What else looks like this? And who in the family, who are we asking? Medical trauma is huge for people with intellectual and developmental disabilities. There's higher medical comorbidities too, and physical comorbidities in people with ID and IDD. They're more likely to have more medications that they're going to take, which means more interactions and more side effects. They're more likely to have more physical issues and things that might cause their oh, that's what I wanted to tell you. I forgot to bring that up. Somebody had mentioned before at the beginning, Down syndrome. So a lot of times people think, how do we know what causes ID and IDD? There's many things that quote unquote cause it. So people who have inherited genetic conditions like Down syndrome or Fragile X syndrome, things that change at the DNA level, they are people who meet criteria for intellectual developmental disorder. So somebody who is diagnosed with Down syndrome can meet this criteria. And I think, I don't know, in Virginia, because I live in California, we have these places called regional centers that are for individuals with intellectual and developmental disabilities to get services like through state monies and all these things. And so they usually are the ones who do all these things, and they, you know, talk to like people with fetal alcohol syndrome can qualify, people with fecal, I said fecal, not fecal alcohol, that's terrible. Fetal alcohol spectrum disorders, or even like an infection as a kid from like rubella can do this, an infection that can change your brain, malnutrition, preterm birth complications can do this, loss of oxygen at birth. So even if stuff can happen, the same things can happen when you're as an adult that can cause similar things, but because it happens later, it's more like a TBI or a medical issue. When it happens when you're a kid, that's what makes it developmental. So oxygen deprivation, sometimes that can mimic, it looks like a youth on the autism spectrum with high support needs and no verbals, no ability to verbalize. Environmental exposure in childhood. So like somebody having meningitis or whooping cough, that's why pertussis, like the need to like vaccinate against pertussis was so huge. Exposure to toxic substances like lead, like the lead eradication, and then severe neglect or abuse, like, you know, shaking a baby, the soft spot on the head, all of that stuff can do this. Even people with like cerebral palsy. So lots of things. And that's why this is also really difficult for practitioners too, because of the range of things that can cause this quote unquote diagnosis. It's kind of just like a placeholder to help people get access to things. Like if you think about the DSM, and I know there's a lot of controversy around having a diagnosis. And if we think about, hey, at least in our system right now, how it is with insurance and services, to have a diagnosis like this is to have access for many people, and especially, you know, caregivers, the family members, and the individual themselves with the diagnosis to have services throughout their whole life to get what they need, because otherwise, if they don't have enough money to do it, which rarely anybody does, that's what this is. It's really hard to discern how to go forward with each individual because you don't always know what they had that caused it. You may know, okay, well, this person has Down syndrome. That's usually the most quote unquote cut and dry, because you know genetic changes, you can tell because there's tests, it's very clear. Otherwise, it's really difficult. And then there's a host of medical issues that go along with each one that change a person's presentation and increase their likelihood for other things and other mental health outcomes. So you'll notice that bipolar and schizophrenia spectrum disorders are the ones that are more likely to be considered severe mental illness. And again, like you all, like Wendy was mentioning, because a person may be more likely to show behavioral issues that would upset the people around them and maybe put other people at risk of danger, because maybe they're hitting and maybe they don't have the ability to regulate in a way that you or I would. They're often more likely to get medicated with things that subdue them and change their quality of life or their ability to get to be who they want to be. So that's always something to consider. When you're thinking about the intersection of these two things, that dual diagnosis, I mean, sometimes it's triple or quadruple, or what's the five? I don't know how to say it. Five-vuple. I know that's not it. Quintuple, I think. That's as high as I can go. When that dual diagnosis is there, it more than significantly increases the complexity of care. It's already difficult enough to think, when somebody can't communicate in a way that we're used to, how to give them care. Is anybody a parent in here? How hard is it it's hard enough to anticipate a baby's needs when they can't talk. And you're like, can't wait till you talk, kid. I'm not a parent, but like, that's crazy making enough. And then when a kid grows up and then they continue to communicate in a way that's different than you as the caregiver, and then, but you know them because you would observe them every day. imagine being a practitioner, you see them the first time and you don't know them from Adam. You don't know anything about them. So you're already up against it. And those communication barriers, in addition to the cognitive changes, they sometimes mimic like a neurological difference. And they might also be at higher risk for a neurocognitive disorder in addition to a neurodevelopmental disorder. So there's layers on layers. And like Wendy was saying earlier, behavioral expressions may be misinterpreted. They're like, oh, you're aggressive. Okay. Thinking about what is the need? Behavior means a need, trying to get a need met. If we can remember that for anybody, that's kind of the point. And then there's a risk of diagnostic overshadowing, that one thing or one behavior can overshadow the real thing. Anybody else? Any concerns about, I want to know, like, if you've had experience or haven't, or you're worried about what challenges you might face if you're working with people in this population, or any experiences or thoughts you might have about challenges in the diagnostic portion and maybe treatment with this group.
I was just gonna say probably what you're about to talk about next, like how do you treat and where do you start?
And what do you do right now? Like what
I'm a
kind of work?
student in psych mental health, MP.
Woo, woo, woo.
Yeah.
Hell yeah. Okay.
hmm
That's great. Do you have a population you want to go work with? Do you know yet?
I'm not sure. So I'm attending these seminars to kind of get a feel, you know.
Cool. I love it. Okay.
Mhm.
Anybody else? Anybody done any work besides Wendy with this population so far?
I haven't directly really. I'm in a state social work position right now as an intern, and so I see it in regards to getting services for the student. I'm like we're coming across right now, even the student who is literally borderline, like at 70, has the IQ, and it's like, how do we? I was talking with my supervisor, like, how do you get services if their adaptive skills are too high? But yet, it's really showing, you know. So that's been an interesting concept to now have this tonight. Follow up on that. Yeah.
Well, and what's interesting is working in schools is a good place to be when you see any kind of intellectual disability. And what really sucks is when there is kind of a cutoff thing. Who are we helping? Who are we hurting? And you're like, are you freaking kidding me? And you're like, oh my God, this person needs something, but they can't get it. What are they falling through the freaking cracks? Yeah.
Yeah, very much. Especially when they're in like first grade, second grade, because it's just starting to like really maybe manifest in school. But is it the assessment, or are they not old enough to understand the assessment, or is it really showing that that's a problem?
Was the assessment like, was it like a full thing for special ed where they were doing like processing, they were doing all of it?
Yeah, all the schools like did all of the educational for what they qualify in regards to the testing for educational.
Well, so a lot of times
yeah.
they will only do some things unless the parent asks for assessments in all suspected areas of disability, and then they ask for it. Because schools are really, I used to work in special ed too.
Yeah.
Schools are really like, everybody's really strapped and it's a ton of work, and psychological testing takes a ton of time, and there's not a lot of school social workers or school psychologists. It's like the ratio is like crazy to students, you know. But a lot of times when there's borderline with an IQ, it can be there's processing, there's visual, they need to get their eyes checked, they need to get their ears checked too, hearing, eyes, their auditory processing, visual processing, which is not the same as seeing and hearing, you know, any kind of sensory things, any kind of, if they did autism testing, if they did anything else.
I do see that they actually do a fairly good job at the counties that I'm at, because they do all those when the school site talks. It's like we did this processing and we did this, like all of it in regards to looking at suspecting that particularly versus like, hey, there's a reading problem.
Also, I forget which one they are, but I can check into it. Some of the IQ tests are racist. So depending on like, and they still use them in schools, which is real crazy. and they over pathologize or underrepresent. They make kids look like they're dumber than they are, black and brown kids specifically, and they're still used in quite a lot of schools. They're straight up proven racist. Let's see. Kaylin, yes, intern at a day support program for adults with developmental and intellectual disabilities. Self-fulfilling yet frustrating at times. What's been the most frustrating thing for you, Kaylin, if you don't mind sharing?
Just watching like coworkers or like drivers or even people who have worked with this population for a long time not be able to check their biases and just treat them not like they're adults, like they're children. And they do
Infantilizing.
have developmental disabilities, but again, at the end of the day, they are adults.
Love it. I love that you see that. So that is great. I love where we're going with that, because, and Robin's saying, I've seen the same thing, discrepancies in counties with childhood testing. Oh yeah, it's hard. And I like to always go in with believing that people are trying to do the best they can. And I do think that's the real thing in the majority of places. And we know how schools aren't getting what they need. And it's unreasonable to think that it's a 1 to 1,000 ratio a lot of times for a school psychologist, which is not doable for anybody. Yeah, Chuck is saying I'm going to have to research the IQ testing that's biased. That's a dang shame. There's also one about Dr. D.S.W put one in about racist school testing, an article. There's one about behaviors too that's racist. So they also usually do behavioral questionnaires about like externalizing versus internalizing behaviors where they're trying to get at mental health, and then also when they call something an externalizing behavior, they're usually looking more like something that they're going to consider somebody. Are they an impulsive ADHD or kind of person, or do they have conduct style issues, or which they're going to blame on a black or brown kid a lot of the times. But there's some of those I think that are racist that were still being used. I'm not quite sure besides the IQ and the behavioral questionnaires off the top of my head if there are any else, but I would check out what Dr. D.S.W put in the thing.
I have a question.
Go ahead.
I know that like SMI probably won't be diagnosed until they're closer to like being an adult.
Yeah.
Even there, like if parents are still involved in their lives as an adult, have you had experience with like parent pushback?
Oh my God, so much. Or parents trying to medicate. And so go ahead. Sorry. Was there more to that question?
No. I was leaning in to listen.
Well, there's a piece that I've seen that happens a lot. So there's often a conservatorship piece that will happen with people with this diagnosis, that a parent or a family member, once they get 18 or older, will like get them legally conserved and then basically have all the control over them, their medical and every decision, so they can tell them what to take. And it's gross and it makes me want to die. And that is really dramatic sounding, but it's true. And so I actually run into that. So I run 2 adult day health centers. They're called CBAS a lot of times, where they're community-based adult services, and they're for anybody 18 and up who has a qualifying disability, which can be a developmental or intellectual, it can be physical. So, but ours are attached to aging services. So there's often a lot of older people, but there are people with the ID, IDD, and the SMI comorbidity, which is typically like a schizoaffective or a schizophrenia diagnosis. And there's people where they're finally by themselves because they're older, and the people who were taking care of them before are dead, and they get to actually make more of their choices because they're only like fiscally conserved, because there's nobody who wanted to take on the role of being their medical choice maker, or who is actually listening to them more. So being a person in that role, having education and training on how to, like, for the conservators to say, look, just because you have the choice doesn't mean you shouldn't take into consideration what they want. So I've seen more about trying to medicate, in my experience, like giving medication to people who don't want it, but they can because they have. And we make APS reports, adult protective services. We just do it because we're like, still, just because they're concerned, they don't want it. They still have rights and we do it. So that's what my team does. Ooh, we're getting big in the chat. Let's see. Schools really push guardianship. Yeah, it's super, I don't know how I feel about it. Have group homes been effective with enhancing compliance and maintaining some sort of independence? Robin, when you say compliance, do you mean medication adherence or compliance with regard to what?
I was thinking of medication.
Yeah, so California, I'm in California, and so we had some group homes for adults with these before. They're not here anymore because it was not good. But I think when we have places, people are still given choice now, even if there's things. So they try, they don't stop trying and offering, but they're not going to push. So I think the adherence rates are higher when there's choice, and when there's choice and buy-in in what medication, and there's choice and buy-in and treatment planning with the person instead of exclusionary practice, which happens quite a lot. And they're just like, no, you're going to take this, and they don't even include the person who it's about. But I used to work when I was like a baby, when I was like 20, I worked in a group home for here with the youth. It was terrible. I mean, it got shut down, thank God, but it was really bad. It was a lot of kids with these comorbidities. And I mean, they were trying to make them take everything. And it was, I'm still traumatized by that. I
I
think.
figured they weren't, but I just wanted to, in case somebody had one and,
Yeah.
figured it'd be more of a negative experience for
Yeah.
some.
I mean, I work with adults now only, and there's things called RCFEs. I forget, God, there's too many acronyms, but they're more like what the place for people who are adults that would fit in this category, maybe with moderate to mild support needs, would be in. A lot of times people are within homes. Like there's this thing called, I think it's the Mentor program, but it's called California Mentor here, where families will get paid to have an adult in their home with these type of needs. It's kind of like adult fostering, which is pretty cool, because then it's like, here you're with the family and you live in a community, inclusion rather than exclusion, keeping people in communities that they're already living in rather than trying to take them away. So I like where that's going.
I can speak to Virginia in group homes.
That would be great.
So I'm a site consultant through the DD waiver, and I work, like I have my clients and I do the assessment, but the treatment plan is really focused on supporters. And so I work with a ton of group homes. And I mean, individuals not technically, they do have a choice. They have a right to refuse medication.
Love it.
In practice, though, I mean, they don't necessarily know what medication they're taking at any given time. They are generally like administered their medication as prescribed. I think the issue is like the DD field is not educated on mental health, and
Nope.
kind of vice versa. So, group home staff don't know what to do when there's behavioral challenges. And so they talk to the psychiatrist, and the psychiatrist is like, well, maybe they don't want to continue to prescribe them a bunch of medications, but they're just kind of locked in and feeling helpless.
I agree. That was a great way to describe it.
Yeah, but I know it kind of gives them the parents or the caregivers that break. I know I've seen it from some group homes in Chicago where I feel like some parents are actually still involved, but not actively taking care. So they're kind of like giving their independence, but there's a lot of challenges as far as, them just having too much independence and causing harm to themselves. But I don't know what's the fine line between being in that group home and having a little bit of independence. The caregiver gets a little break versus it being a bad thing to where they're actually being mistreated or, abused.
Yeah.
I
Well,
feel like there's a fine line.
Yeah, and it all depends on each person and each family, and there's just everything's so complex with every individual. Like there's so many challenges that we were just describing, but even in diagnosing the right mental disorder, severe mental illness aside, is already difficult enough. But if there's severe mental illness superimposed over the IDD, symptoms may be overlooked or misattributed, like we were talking about this whole time. That's the number one thing that happens all the time. They're just like, whatever, they're misbehaving again. Let's, just do something to stop it from upsetting our status quo, because that's all they know how to do. It's not that they're trying to be mean, they're just trying to help. There's few evidence-based treatments validated for these type of dual diagnosis. Because there's so much nuance, there's so much difference, there's so many medical factors that might be present. It's just like, what do we even do? So when I know personally, when I'm faced with like, oh my God, there's so much nuance with anything, I go, and I feel like my head's going to explode. So that's what most people do. We either shut down or we go with what we already are doing. And most people just go with what they're already doing or what they know from something that's kind of close to it, because doing something is typically feels better than doing nothing. And we're still trying to help, especially if you're a helper, you want to help. But a lot of times that help is actually more damaging. And like everybody's been saying, there's limited provider knowledge. And when it's like, oh, I'm in the DD field. No, I'm in the mental health field. It's like, okay, there's there's tons of overlap, people. We shouldn't be siloing. And the interdisciplinary training, like I also work in, we have a PACE, a program for the all-inclusive care for the elderly. It's a mini health plan program. They're all across the nation. But we have we have a rural one in California, and it's like, we also have the highest penetration rate in the whole United States because we're awesome. But anyway, it's a whole interdisciplinary team. I mean, it's huge. That's the whole model. There's primary care physicians, there's, NPs, and there's MDs, DOs, there's physical therapists, occupational therapists, master's level social workers. My team is the behavioral health team. One of my teams is the behavioral health team. There's registered dietitians. I mean, there's just this every huge thing you could think of, and everybody tries to think from what their discipline training was, and then think from other people's perspectives how to best help each person in the program. That's cool. That's unusual. There's barriers in accessing care and coordinated care in general, but let alone coordinated and equitable care. Let's see. Have group homes been, oh, do we already get to that? Yeah, we already did. Okay. Okay, let's see. What I really like is, if anybody's done any work, I'm not a huge fan of like ABA, and I'm not saying this to be disparaging to anybody who is, but when there's people who, when you're trying to train people to behave in a way that they're not meant to behave, that their brains and their bodies can't do, it's really difficult. Like say taking a person who's on the autism spectrum and saying, I want to make you act like a person who's not on the autism spectrum. That's like fitting a square peg in a round hole. Like that's, why are you doing that? Let's work with the way somebody is rather than trying to make them the way everybody else is. But a functional behavior assessment is not ABA. It's really a really great way to start with an assessment and diagnosis. What is the function of the behavior they're doing? That's observation. You're going to need to rely a lot more on observation than direct interaction with a client that might fall into this domain. You're not going to be asking a lot of questions like you would in a direct one-on-one mental health assessment. Say if you're doing individual therapy, it's a different thing. You're going to have to rely on different ways of assessing than you're used to doing when somebody can communicate the way we're communicating. There's modified mental health screening tools like that are adapted. There's not a ton, but like for a depression scale, there's a Glasgow depression scale for people with ID that has shown some good use. And when you combine self-report, if a person is in that space that has ID to be able to do some self-report with observation and the caregiver or support system input, that's when you're going to get the best information. But always adding observation. You need to observe, and more than once. Observe them in multiple environments. Because you need to see, hey, are there certain people, situations, are there things that actually improve how they feel? And then always, this is the best thing, rule out medical causes first. There's a ton of medical things that change people's behavior. I mean, especially if it's an older adult, a UTI can make them look like they're having a psychotic episode. It looks like psychosis. So especially if it's an older adult who was already having this their whole life, who has ID, and then all of a sudden they have a UTI, medications make changes in behavior. So always ruling out medical causes first is a good place to start. And then, like we talked about, atypical presentations, being open and saying, okay, I'm not going to assume that this behavior is only one thing. Let me be a detective. Let me open my mind, like Wendy was saying, and maybe these behaviors are related to trauma. Right here, you have to consider a trauma history. Who are you going to ask? Who are you going to actually talk to? You're going to say there's trauma-informed frameworks that you can use. Behavior changes, it's hypervigilance, dysregulation. There's reasons why people are dysregulated. Maybe their interoception too, like interoception, your ability to understand the internal cues. When somebody has intellectual or developmental differences like this, that can be skewed, just like a neurological disorder. They might not be able to understand the internal body cues, like going to the bathroom, like when they are hungry. And so they might start changing their behavior if they're really hungry and they haven't eaten. So helping people establish a routine is going to be better. And when I was mentioning the atypical presentations, like depression, like I mentioned in teenagers, irritability and withdrawal might indicate depression. Anxiety might be like increased repetitive behavior. It might not be like, oh God, I'm so worried, because they're not, if there's different verbalization, that's not what you're going to hear. And things like pain, sensory processing issues, sleep disturbances, that's something that can make anybody behave differently. If we're looking at being person-centered, we need to think about what's developmentally appropriate. Person-centered planning in this context, we're always thinking, number one, what is developmentally appropriate for this individual and their situation? Number one, what is functionally appropriate for them? Have we adapted for their communication needs? Are we including them at every step instead of just talking to their supports? Are we including them as much as they want to be included? Sometimes people don't want to be included. Have you ever run into that? They're like, no, that's a real thing too. I'm not saying, like, trying to force somebody to be included can also be detrimental. Considering both the mental health and contextual factors, always, always, always include the support people. Okay, we're getting to the last half hour. And right here, the biggest intervention strategies, like I already mentioned, person-centered planning is obviously great, but integrated dual diagnosis treatment, if you're lucky enough to be in a place, which this is probably like a pie in the sky kind of thing, there's only very few that I've ever run into that have this, and they're usually related to those things I was mentioning earlier that are called the regional centers where I live, and not all of them have it, but they have specialists who understand, they coordinate services and offer groups or individual services that understand both of the needs, where the treatment is based on improving like the depressive symptoms that they have while also addressing their own specific functioning based on the intellectual disability. And it reduces the fragmentation of care, where they don't have to go here for something, they don't have to go there for the other thing. It's all together. Like, I don't have to go all the way across town with a different provider for my mental health and here for my services where I get supports in the home because I'm getting respite. So my caregiver can have a break. It needs to all be together and coordinated so that we don't all lose our freaking minds. I mean, that sounds really simple, but it doesn't happen. And the barriers, that's so much stress for people that they just don't even do it because too many service providers is so stressful for people. Too many places that they have to go and appointments that they have to remember. It's like another full-time job. Positive behavioral supports in schools, they'll call it like PBIS and stuff, but positive behavioral supports. The emphasis is on service providers to coach the people in their environments, like whether it's a group home, whether it's a home with their family, whether they're in with a mentor, to set up their environment in a way that supports them. It's not on the individual to do that. They have adaptive functioning differences, and we need to coach the people around them who don't have those differences to set up their environment for success and help teach new skills that support them in living the way that's going to reduce dysregulation. You know, it's just like dementia. If a person's brain changes and they can't remember things, how are you going to expect them to regulate? They can't even remember where they put their pants. That's unreasonable. You can't put unreasonable expectations on somebody when they're not able to do that. So a lot of it, when you don't have a support system, that's the hardest part, though. There's a lot of unattached people whose families were unable to keep taking care of them, and they have maybe put them in a group home or a state hospital. A lot of states still have state hospitals. And some care is not very good there. And it's pretty difficult. There's been like one state hospital, I forget where it was, that I saw that was actually pretty good, and I was surprised. But of course, I think it was an affluent place that had a bunch of money. You know, money talks, right? Let's just be real. If you have money, you can do a lot more things. And then skill building interventions, skills trainings, where you're giving emotional strategies and coping tools that you adapt. There's curriculums that they adapt for how to regulate. And a lot of times it's just based on the cognitive level of a person. So if you're teaching somebody how to calm down when they're dysregulated, it's not usually a lot of words if the person's verbalizing, and it's a lot of hand over hand doing it while they're doing it with them. So if you're a person who's ever done a functional needs assessment of activities of daily living, if you've ever heard that, that's the basic functions of what people do to care for themselves, like toileting, like being able to go to the bathroom. What level of help do you need? Can you do it independently, or do you need different help? Eating, your mobility. There's like 8 different regular activities of daily living, and then there's instrumental activities of daily living. Like, are you independent, or do you need different levels of help, like with your finances, using the phone, transportation, things like that? And making sure you know what level of help they need with things like that, because, excuse me, adapting those things where you show them and do it with them, that's going to be really big. Adaptive curriculums are the best. And emotional regulation training with people who have different communication than you has been some of the best things I've ever done in my life. Teaching coping skills like that to people who have cognitive functioning like me, yeah, it's great, super rewarding. But I've done like breathing classes with people who don't verbalize like this, and by putting our hands on each other, like when somebody's getting upset, we put our hands out and we breathe together, and they look at me. So at that point, after so many times of doing it, the act of putting your hands towards somebody, that's the cue. Like, you're doing kind of like Pavlov's dogs, right? They see the cue and they know it means time to calm down. You're already telling their body, you've trained their body to know that it's already time to regulate. And then after so many times, I'm going to cry. They saw somebody else getting upset and went to them and did it. You know what I mean? So like, there's things that you can adapt. What we know about the body, what we've learned about trauma, what we've learned about how to regulate, all the somatic things are really powerful. You can adapt a lot of those things, and there's a lot of analogous things from trauma that you can adapt that have no words needed, which are always really powerful in my opinion. And the care models that are really good, like I mentioned, always a multidisciplinary team approach, because when you have somebody who knows about like an occupational therapist, they are freaking amazing. If you ever have a chance to have an occupational therapist on a team you work with, get them. It's like social work, physical therapy. I swear, it's amazing. Any multidisciplinary team you can have, more than one way of thinking is always going to produce a better outcome for a client, and it's going to create creativity. It's going to make everybody be a better practitioner and find more creative ways to solve problems. And there's modified psychotherapy. There's adapted CBT and DBT and other evidence-based modalities that people have done. It's a little more tricky. You have to usually shorten the sessions. So that's one of the adaptations, is shortening the time that you do things like that. And you're using more visual supports, less words, and doing repetition. So if you're using words, it's really concrete, kind of like more in the behaviorism vein, and you're giving like one sentence and a lot of wait time in between. And group is often a good way if you have people who are in the same cognitive level, because a lot of people like to be social, right? And then you're getting social interaction too, which is good for everybody. But the DBT piece, I know that's surprising. Sometimes people are surprised when I say DBT with this, because a lot of times they hear dialectical behavioral therapy and think personality disorders. But those pillars of DBT, like the one about God, oh my God, my brain's blanking. When you're trying to regulate, what's the word when you're getting your distress tolerance? Gosh, ooh, it's been a long day. The distress tolerance skills, when you adapt those for people who are having all kinds of trouble regulating, which oftentimes people with IDD are, it's not like you're doing the whole model of DBT. You're doing those main things that really help. And it's really helped quite a lot of people. And you can also teach that to caregivers to help them as a reminder at home. And the biggest thing that is really good if you're doing any kind of modified psychotherapy with a person with IDD is that you don't have to. It's best if you have a person that they have at home that you can engage, as well as what you'd call a transfer coach, because you need somebody to know the skills as well that they can prompt them to do at home. Because if you're teaching skills, the whole point is that they can use them across environments, not just with you. Because you're seeing them maybe an hour in a week, maybe two if you're doing something higher needs, but that's not, what is that going to do? What is that going to do? Yeah, it's giving the person a break that cares for them, but that's only an hour respite. A transfer coach is just, it's kind of, I think it's the most important, and if you can do it. And then medication management. Psychotropic medications, they're often given to people, especially if they think there's any hint of psychosis, which they'll interpret the way people with IDD behave oftentimes as a psychotic episode. So a lot of times there's really not a way to know if it's a true psychotic episode or not. And that's what's scary, is it can look like severe mental illness, but it may or may not be. And that is one of the hardest things about the intersection between what we might think is severe mental illness, and is it is it a presentation of how they're feeling? Are they trying to communicate? Is it true a psychosis, or is it not? So consider the risks and the side effects before, like Robin, are you going to be like a psych NP, you think, or what are you thinking about? Yeah. So considering the risks and the effects, obviously, especially if you're going to be a prescribing person or a person who is on a team and can give input. and say, hey, I know this family doesn't really want drugs. Is there anything that has the least side effects? And then health promotion and social inclusion, anything you can do to improve social inclusion and have physical activity in a routine. So day programs are freaking awesome for everybody. Day programs. If there's any kind of community program that anybody really can go to and they have access to, and it's not a financial burden, I always recommend having somebody go to it, because that is a mental health intervention in itself. Social inclusion, routine, nutrition, and hanging out with people. And those day programs, they often have a nurse, they have social workers. I mean, ours does. We have it, mine do. Yours doesn't, Wendy? California, man. Go ahead.
Virginia's like next to the bottom in funding for DD services, and
Girl.
there's a lot of day programs, and I have individuals who enjoy them, but I've rarely been impressed.
Oh, okay. I rewind. California, Dave. I'm sorry, Wendy. If you can check out the day program before you recommend it, yes. I guess also there is a difference, a day program and a day health program. When there's a word health in it, there's usually a nurse. There's a distinction. And it's pretty fun when it's good. You're right, Wendy. Dang.
I
That
try
made
to
me
get
sad.
people working. I say, if I'm working, you should be working. What are we going to do about it?
I agree. And then crisis prevention and planning. Somebody mentioned that earlier today in our session, but making sure that you're letting the caregivers and the professionals that work with individuals know about early warning signs of potential blow-ups or crises, and help people understand about de-escalation techniques. And so that also includes helping people know how to set up their environments, how to not make people feel backed into a corner, how to give people space, and just that comes down to how to lower your voice, how to, have your body language when you talk to people. And then caregiver support, always number one. If there's a caregiver, any way you can get respite care with somebody who's safe so that person can have a break. Caregiver groups and support for the caregiver, because the behavior changes that happen for the individual are often because of what the caregiver does, not what the individual does themselves. The caregiver and how they change the environment and how they behave. And here's my last slide before we can maybe have some questions and some conversation. I like to say, remembering it's about the whole person, and that IDD, it's not just about IQ. A lot of people I run into still, even if they've been in this kind of disability space for years, they're like, they still think it's about quote unquote intelligence like that. It's about adaptive functioning and support needs. And so considering the individual's strengths, preferences, and goals, you still have to do that. You still should do that, because they do have strengths, preferences, and goals. And the way you're going to find that might be different than you're used to. So observation is going to be a way that's going to help you do that. You can tell what somebody likes. If you're going to need to see somebody to do a medical evaluation, and it's hard for them, but you've observed them before and they really like a certain handheld game, have them bring it. Have them bring it every time. Whatever you can do to make a person feel like themselves and still get things done. So getting really creative like that. And then remembering that mental health matters. Of course, that's the whole point of this today. And that the mental health disorders, they're so common in this group, but they're often overlooked because people don't know what to do. And don't mistake the behavior for just the disability. And that's what we see often. That's what we see in people who don't really understand that it can be both. And assessment requires adaptation. You cannot just take an assessment off the shelf that is made for a person that doesn't have IDD. You cannot do that. They're getting more and more assessments adapted It's definitely very small amount. But anything you can do, if you're a person who is working in this field and you're a person who has been educated or wants to get educated in working on how to adapt tools like that, I really, really encourage you to do that. Because as we might know, the way that people understand if there's a problem, there's people who work in the field and they see, oh God, there's an issue. Like Wendy, I keep mentioning you because you said you worked there for 25 years and you're on my screen, but you have more direct knowledge than a lot of people. So you might be uniquely positioned to say, okay, well, I might be a person who could consult on these things and then we could test them and we could do these things and get them normed. So everything takes so much time. And there are unique people who would be the ones who would not only socially advocate, they would know what to look out for, and they have the direct knowledge. That's what I always like. Because there's a lot of people who do the adaptations of things that know nothing about the population. And you're like, did you think about how you needed to adapt this? What? And then they try it out and they're like, that didn't work. And it's like, yeah, I can understand why it didn't work because you didn't actually think about the person or the population. Did you talk to anybody in the population or that works with the population? And then caregivers
Sorry,
need,
with the assessment, there's a book, the DMID2, which is an adapted DSM pretty much. And
Yeah.
it's an amazing resource. And it has, I mean, it's laid out just like the DSM, but it has like research articles and all different resources for each diagnosis and adaptations based on level of severity that are pretty good.
and what's hard is that, have you ever noticed how people don't really respect it very much?
Yeah.
And they're like, well, I don't care because I can't. Is that how it's written?
Mhm.
DMID2?
Yeah.
People are like, I can't use this to put in a diagnostic code in insurance, so I don't care. I mean, it's like I don't know, people are jerks.
Yeah, I use it.
Well, yeah, because you're smart. And I think it's so weird that we have to get so hung up on books. There was also this one that was like almost like a DSM for 0 to 5 too, that I really liked. I mean, it wasn't just about IDD, but it was also thinking about, because 0 to 5 mental health is also a thing that is really hard for a lot of people because they think, how are we supposed to think about people who can't talk, little babies, and generational trauma, and how can a baby, what we know is babies can come out pretty traumatized, especially if they were in a mom that was traumatized while they were pregnant. And 0 to 5 mental health is getting treated kind of like this too, in case anybody wants to look into that. But yes, thank you for mentioning that, Wendy. And then remembering this again, behavior is communication. So anytime you're training anybody, or even if you're not an expert, because like whoever feels like they're an expert, because that's just a weird thing to say, letting people know, hey, they're not really trying to do this just to piss you off. A behavior that's happening is because they're trying to tell you something. Behavior is communication. So anytime you can tell anybody that, like, just like with kids, yeah, it's annoying when kids do things that are annoying, but they're trying to get a need met. Most people are trying to get a need met when they're doing something that seems upsetting or out of the ordinary or aggressive, and especially people who have differences in their brain or differences that make it very, very difficult with impulse control or emotional regulation or anything like that. And, this is my little sweet social worky lead with respect and belief. And so that just because there's differences in brain function and adaptive functioning right away, doesn't mean there shouldn't be respect. And I think that people think, duh, but it needs to be said because we don't really realize until it happens to us how much our bias is still there, how much is in there when it happens in our faces. And as a person who does work with different groups, and I've done work with people with developmental disabilities and people who are aging for a really long time. And I still have to check my biases, and I'm still surprised at myself when they come up. I'm still surprised. The other day when I was like, oh, this is really great that, oh, not every older person acts like this. And I was like, did I just have that thought? Did I just like get so, I was like, did I just think that, am I going around with all my older clients thinking that they all think like this? Geez, after doing this for so long. So as long as you can talk to yourself, check yourself, and with your colleagues as well, that you can say it's okay when that comes up, as long as we talk about it and as long as we recognize and remember that we should do something about it. Okay. And then here is my information. And I'm wondering if people have any thoughts. Who is hot in here, or questions, or just want to have a conversation for a little bit, or if you can run away if you want to. But if you haven't filled out your attendance thing, it's a little bit further up in the top from Dr. DeSena Jacobs. I think she needs that for everything. But anybody have any questions? Yeah, see, she's putting it back, the form, she put it closer.
I have a question. I don't know if it's appropriate for this audience or not, but I work in a residential program. I work with adolescents.
Wonderful.
And there are times where we get kids who have sort of an ID diagnosis and they've committed sexual offenses.
Yes.
So how it's challenging to figure out how to work, how to do that. Do you have any thoughts, suggestions, resources for that?
How to like work with them, or do what? Like assess them, or what is it that you're wondering?
So we can do the assessment part. That part we can get done, but to do the actual treatment work has been incredibly challenging because I think part of it is our program is really heavy in cognitive DBT, CBT, that kind of stuff. But I don't know what else to use.
Well, so are you also thinking that maybe you all shouldn't have accepted somebody like with
Oh, I think that a
diagnosis?
lot.
Yeah.
Sure. I think that, yeah, of course. I mean, I think that a lot, but there aren't many programs
Right.
because of the sexual offenses that limits where a lot of these kids can go.
Yeah. I would recommend adapting the CBT, and I can give you some stuff, because what you can do is you can do that. You need to do like shorter sessions and then just use less words and expect them to do less homework, probably no homework.
That's
And
fine.
yeah,
That's fine.
things
That's
like
fine.
that. So it's really about like thinking about it. If like if you would think about what the developmental age, can you tell what the developmental age of the person would be if you would, like they might be
Yes.
6, you think they're 5. How would you think? How old do you think they would be
So
developmentally?
right, the child I'm thinking of is 15 in chronological age,
Mhm.
but in developmental age is probably closer to 9 or 10.
Okay. And have you ever worked with a 9 or 10-year-old in CBT?
I have, yes.
Starting there is always a good way. Is anytime you can think about the developmental age of a
Okay.
client you're working with is always a good way to start your first adaptation and see if that makes a difference. And then always definitely making something shorter is always a good way. But I think let me write this down. Bless you for doing that work. And also, I love that you brought that up about, that's a weird thing to say. I love that you brought up that the sexual abuse happens, but a lot of times the sexual offenses that happen with people with IDD, that freaks people out too, because sorry, people are going to want to have sex, right? And most people want to have sex regardless. And when people don't understand social cues and things, and then they can get labeled as a sex offender, that is really hard. So protecting somebody and helping people understand that it's okay to have sex or want to have a sexual desire is really difficult for a lot of people. And then protecting the person so they don't do something to get themselves in trouble, that's really hard.
Right.
Yeah, that's a
Yeah.
real struggle. Okay. Somebody's writing something in the. Okay, and.
Yeah, you have 2 more questions in the chat.
I'm looking, thank you. Um, Kaylin, I think I have something, but Wendy, do you have a skills training with adults? With
Yeah.
IDD? I have something from our CRC, but since you might have something that Virginia uses, that might be good.
Not all of Virginia, but Julie Brown, she has adapted DBT and has the skills system. And at one of my previous agencies, she actually came in person and worked with us. The whole system is a little in the weeds for me as far as like has its own terminology that can be a little much, but the book is full of PDF worksheets that you can download, and I use some of those like every day, like effective scaling things that are.
And you piece it out.
Mm-hmm.
That's smart.
And then also supportive therapy is really important. Most of my clients, nobody has ever just like listened to them.
Yep.
And that can be super helpful, and you can go from there. Like, oh, you think that is a thing?
Yep. It's huge. Validation is so huge. Letting somebody be themselves without being like, do this, do that, do this. And oh my God, that is the biggest deal. Hey, Tara, do you have to do CBT at your place?
No.
Do they use, okay. Yeah, I would
No.
suggest supportive. Okay. I would definitely suggest supportive therapy too then.
Well, yes, and my problem is I've got to get these kids to court. I have to show a judge why they don't need to be on a registry. Like my challenges are here, and so I have to do more than just supportive.
Also, Karen Harvey, she has done a ton of work and does some amazing trainings in positive identity development.
Mm-hmm.
And you Google her. She's an extra Y in her name that is unexpected, and I can't remember.
Karen with the Y?
Karen Harvey.
Oh.
But all of her worksheets and her books are free online, and she uses more exclamation points than I prefer. However,
Is she a millennial? Said, is she a millennial? Sorry.
No, she's not.
Can you write her name in the chat? And then we probably do have to end because we're really bound. I don't mean to, because I will talk to you forever, and Dr. DeSena Jacobs know that, but they're bound to end at certain times so we don't hold people and ruin things. She knows I will talk forever because I do that. Yeah, that is a
Stephanie,
lot.
I did copy your question and I emailed it to Dr. Day, so I will make sure that she gets your
Oh,
question.
I wrote it down too. Polypharmacy.
Okay.
But yes.
Yeah, they are making sure that these are at 90 minutes for our recordings. Thank you all for coming. Thank you for the lively conversation you had with Dr. Day. So you don't need me to email it to you, Sam? You got the question?
Yeah.
Okay. We have one more of these, our last one of the series. It is on the 24th. It is with a psychopharmacologist that works here at VCU Health. I think it's going to be really great. It's our last one of the series. So, please consider attending that one as well. Again, that one is because we had a request for a psychopharmacologist. And so we have a psychopharmacologist coming for the last one. So thank you all for attending, and hopefully we'll see you for our last one in 2 weeks. Have a good night.
See y'all later.
Thank you.